Welcome. It is for me truly a privilege and an honor to be able to introduce today's President's Plenary guest lecturer, Dr. Adashi. Dr. Adashi is a reproductive endocrinologist for the better part of 40 years. He served the cause of the discipline as President of the Society of Reproductive Endocrinologists, President of the Society for Gynecologic Investigation, as President of the American Gynecological and Obstetrical Society, and as examiner, member, and director of the Division of Reproductive Endocrinology of the American Board of Obstetrics and Gynecology. A graduate of fellowship programs at both Johns Hopkins and UC San Diego, under the direction of Drs. Howard and Gianna Jones and Samuel Yen, respectively, Dr. Adashi has focused the bulk of his research on basic ovarian biology. Dr. Adashi has focused on ovarian biology, for which he received continuous NIH funding from 1985 to 2005, inclusive of a Research Career Development Award. More recently, Dr. Adashi has refocused on his attention on matters at the nexus of medicine, law, ethics, and social justice. He's been a mentor to over 50 postdoctoral trainees. Dr. Adashi has authored or co-authored over 350 peer-reviewed publications and over 120 books and reviews. Dr. Adashi has also co-edited or edited 13 books in the general area of reproductive medicine with a special emphasis in ovarian biology. He is the former Dean of Medicine and Biological Sciences at Brown University, and he is a member of the National Academy of Medicine, the Association of American Physicians, and the American Association of the Advancement of Science. So I welcome Dr. Adashi.
Thank you, Aaron. Mr. President, thank you very much for this kind introduction. Members of the Society, distinguished guests, friends, colleagues, ladies and gentlemen, good morning. As we stand here today, all but 40 years since the birth of Louise Joy Brown, we continue to marvel at the legacy of Edwards and Steptoe and at the enormity of their accomplishment. In so doing, we also recognize the indispensable contributions of Leslie Brown, an unsung hero who displayed nothing but dignity and grace. We likewise remain in continued awe of the seemingly unending string of innovations that appear to be coming our way, with no obvious sign of a slowdown in sight. But most importantly, we celebrate the estimated 6 or more million families worldwide, traditional and non-traditional alike, whose infertility has all but been vanquished by IVF, and who, against all odds, were afforded the gift of life. And why not? After all, what is more fundamental than the right to procreate? A right that is baked into our DNA, a right that is inherent to our very existence as a species, and a right enshrined now almost 70 years ago in the Universal Declaration of Human Rights of the United Nations. And I quote, "Men and women of full age, without any limitation due to race, nationality, or religion, have the right to marry and to found a family." In principle, then, the precept of procreative liberty is all that is necessary and sufficient to undergird the right to infertility care in general and assisted reproduction in particular. In keeping with this premise, the World Health Organization defined infertility as, and I quote, a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. In a word, infertility is a disease. Just as importantly, the World Health Organization included infertility in its international classification of diseases, replete with the corresponding billing codes. And yet, ours is a house divided. Divided by the realization that the promise of procreative liberty and all that flows from it has yet to be fully and equally realized. What is more, the universal principles just enunciated remain to be uniformly embraced by all member nations or by all member states of the United Nations, including the United States of America. More to the point, ours is a house divided by a gaping technologic chasm, widening income disparities, extensive underwriting gaps, deep-seated social-cultural cliffs, and profound moral discords. Viewed more expansively, ours is a global house divided by the very availability of IVF technology worldwide. Global IVF activity data assembled painstakingly over years by ICMART, IFFS, and ESHRE's European IVF Monitoring Initiative reveal that 92 of 193 sovereign nations either lack or fail to report the existence of an IVF program. 28 of those states are not showing here due to their modest land mass. Incomplete and imperfect as these data may well be, there is no denying the paucity of IVF activity in sub-Saharan Africa. The contrasting ubiquity of IVF activity essentially all around the world is equally apparent. Similar conclusions could be drawn from the global IVF clinic density data as expressed per 10 million persons. Apart and distinct from the foregoing access and distribution challenges, our all too divided global house is frequently burdened by the high costs of assisted reproduction, which are all too frequently painfully juxtaposed against widening income disparities and the backdrop of limited underwriting. To those seeking to build a family, the confluence of these hindrances is nothing short of prohibitive. The net effect being that of access all but denied. None of this is surprising, of course. After all, access equals affordability, which regrettably is unlikely to improve anytime soon, given widening income disparities between as well as within nations at a time when universal health insurance is at a premium worldwide. If there is a silver lining here, it is that the universal health coverage as a goal has been defined as an overarching principle by the Global Action Plan of the World Health Organization, which is to be accomplished or at least aspire to between 2013 and 2020. In the United States, ours is a house just as divided, if not more so. Indeed, some of the most profound elements of procreative liberty remain significantly shortchanged. Leading the pack is the matter of underwriting of infertility care, to which the definition of infertility as a disease is central. Although the ASRM board has defined infertility as a disease as far back as July 17, 1993, and affirmed and reaffirmed the same in 2008 and yet again in 2013. No other credible public or private entity followed suit. Congress and the Supreme Court of the United States have characterized infertility as a protectable condition and as a form of disability, respectively. This hands-off approach to the definition of infertility and to the underwriting thereof is quintessential American. Drawing on a rich vein of libertarianism, which, as you all know, imbues our national identity, but more importantly, our Constitution. What is more, the pluralist democracy that is the United States, unlike the social democracies of Europe and beyond, is on balance far less embracing of notions such as big government, cradle to grave, or a national health insurance. Absent the necessary legislative, judicial, cultural, and political support, not to mention our failure to define infertility as a disease, neither the private nor the public sector bear any formal responsibility for the underwriting of infertility care in the United States of America. Perhaps one of the starkest illustrations of this reality is afforded by the all-important Patient Protection and Affordable Care Act of 2010, wherein infertility care, perceived as too costly, was not deemed an essential health benefit. It should therefore come as no surprise to anyone that the underwriting of infertility care in the United States has been characterized by high under and uninsurance rates, high out-of-pocket expenditures, absent public payers, limited private payers, and a total of 15 infertility state mandates. This state of affairs has been characterized by many as dismal. and by some as socially unjust, in that it would appear that family building in America may have become a function of one's economic prowess. A poignant illustration of this reality is perhaps best afforded by the latest national survey of family growth of the National Center for Health Statistics of the CDC, according to which the ever use of infertility services in the US was highest among non-Hispanic white women with higher level of household income and higher levels of educational attainment. Nowhere is our American house as divided as it is across the public-private underwriting fault line. On the public side of the ledger, mention must be made of Medicaid, Medicare, the Federal Employees Health Benefits Plan, the VA, and the Indian Health Service, all of which have consistently skirted the prospect of infertility care, let alone the underwriting thereof. One notable, indeed commendable, exception is TRICARE, home to 9.5 million active duty beneficiaries, many of whom women, which subsidizes ART for all its beneficiaries, thereby having given rise to 1,200 ART cycles in 2013 at an out-of-pocket cost of less than $7,000 per cycle. What is more, TRICARE covers the entirety of the cost of ART for so-called wounded warriors, that is to say, severely injured service members in the line of duty whose reproductive function has been severely compromised. The US private underwriting universe, in contrast, is dominated by self-insured employer-sponsored plans that are home to approximately 60% of private sector enrollees. Unpublished survey data for over 1,000 employers, kindly provided to us by Mercer, a human resources consulting firm, reveals that employer size is a major determinant of the inclusion or exclusion of IVF from the benefits package. As shown, mega employers with 20,000 employees or more are more likely to include IVF in their benefits package than smaller counterparts. These same conclusions appear to hold true for the non-IVF component of the benefits package, such as a visit to the reproductive endocrinologist, attendant drug costs, and superovulation and IUI. The Mercer data further reveal that employers headquartered in the Northeast are far more likely to include IVF in their benefits package than Midwestern, Southern, or Western counterparts. Here again, the data appear to hold true as well for the non-IVF component of the benefits package. With infertility mandates in some, but not all states of the Union, ours is a house divided yet again, albeit this time across state lines. All told, 15 states are home to an infertility mandate, the ground rules of which vary widely. Some indeed reject IVF outright. Yet others retain social, cultural elements that are no longer consistent with existing law, let alone with a 2013 opinion of the Ethics Committee of the ASRM. For example, 7 of the 15 state mandates deem single-parent families ineligible by dint of spousal requirements. Thus far, only California has taken corrective action in a manner which can only be described as exemplary and as a model for our times. Similarly, 11 of the 15 state mandates deem same-sex couples ineligible by dint of the clinical definition of infertility. Thus far, only California and Maryland have taken corrective action. Shown here is the revised, updated Maryland statute. New Jersey, for its part, is in the throes of a highly publicized lawsuit wherein several same-sex couples contend violation of their due process and equal protection clauses of the 14th Amendment. That trial is ongoing. Lastly, 4 of the 15 state mandates constrain eligibility by age, which presently runs afoul of Section 1557 of the Affordable Care Act. Thus far, only Connecticut has taken corrective action, as is shown by this 2015 bulletin of the State of Connecticut Insurance Department. Finally, ours is a house bitterly divided across moral fault lines, representing opposing convictions on matters of life and choice. One casualty of the pro-life, pro-choice debate is human embryo research, which to this day remains ineligible for public funding due to the 20-year-old Dickey-Wicker Amendment. Mercifully, so far, the clinical practice of assisted reproduction has largely been spared ideologically motivated interventions, save the occasional state personhood amendment and the ongoing embryo adoption initiatives. It is likely that this off-the-grid existence, if you will, of the clinical practice of assisted reproduction is attributable to the private sector affiliation, to its widespread acceptance as a highly credible technology, and perhaps grateful legislators who have experienced IVF firsthand or perhaps indirectly through members of their family. Regrettably, this immunity does not extend to the public funding of infertility in general and IVF in particular. As already mentioned, none of the existing public assistance programs of the United States either engage in infertility care or seek to underwrite it. Even the so-called TRICARE exception, which we mentioned earlier, is truly an internal initiative of the Department of Defense as distinct from congressional action. Repeated legislative efforts over the years to add IVF to the federal employee health benefit plans have been consistently stymied, going all the way back to 1987. A similar fate, as you have heard briefly already, befell the VA, home to 10 million veteran beneficiaries, many of whom women, who for the last quarter century have been effectively deprived of infertility care due to the Veterans Health Care Act of 1992, and I quote, "The Secretary of Veterans Affairs may provide to women the following healthcare services, not including infertility services." Repeated legislative efforts to underwrite infertility care, at least for injured veterans, have likewise been repeatedly blocked by conservative members of Congress who were opposed essentially single-handedly by Senator Patty Murray, a Democrat from the state of Washington. Finally, as you heard earlier today, just before this meeting, a Murray amendment was finally enacted into law on September the 29th by way of a continuing funding resolution. Here's what the PBS NewsHour had to say about what clearly has been a persistent congressional logjam.
There's no sign Jason Hallett is at all frustrated with the injuries he's suffered and what they've done to his life. But the same isn't true for the way he feels about Congress. What do you think about the people who have been holding this piece of legislation up?
It's very angering, and it brings a lot of resentment towards my active service and stuff. I don't regret joining the Marine Corps, but the simple fact is they told us that we'd be taken care of when we got injured, and I guarantee that if it was, a congressman's kid or them themselves that wanted IVF and they had to go through the same process and the same hoops, that they would be doing everything they can to make it happen.
It's hard to know that he would protect them and he would give up all of this for them, and they will not take just a little bit of time to try to fix this issue that we're having.
So what is the cost? One estimate says covering IVF and other fertility treatments for veterans for 5 years would be $578 million. Some IVF advocates say that estimate is inflated. We reached out to the two Republicans who run the Veterans Affairs Committees in the House and the Senate. Neither would speak with us. Republican Congressman Jeff Miller from Florida, chairman of the House VA Committee, gave us a statement saying he was trying to balance the needs of veterans with the concerns over IVF.
Several sources told the NewsHour that these concerns over IVF apparently come from pro-life organizations who object to the treatments. These groups argue that because some of the embryos created or stored during IVF sometimes get destroyed, IVF is then similar to abortion. We reached out to the main pro-life groups to talk about their concerns, but they all declined our requests.
What I would answer to that is that this is a decision each one of these men and women have to make on their own. And if they decide this is the way that they can have a family and become whole again, that decision should be up to them. But our country should not be deciding for one philosophy, if it's a religious philosophy, a ban on all Americans who served our country in having the ability to have a child.
Any lingering doubts about the pro-life position on the public funding of IVF evaporated on July the 13th of this year in the context of a markup session of the Committee on Appropriations of the U.S. House of Representatives. On that occasion, Republican Representative Andy Harris, a Maryland-based physician, sponsored successfully an amendment which links the public funding of IVF to a prohibition of embryo destruction, thereby effectively linking the Dickey-Wicker principle to the clinical practice of assisted reproduction. Here is what Dr. Harris had to say.
Thank you very much. Mr. Chairman, what this amendment does, this amendment extends the Dickey Amendment ethical protection to embryos created with government funding under the IVF program, the Department of Defense, and in the VA that was just created by the conference report that passed the floor 2 weeks ago.
On this vote, the yeas are 29, the nays are 21. The amendment is agreed to. Committee stands in recess until 9 a.m. here.
Shown here is the actual text of the Harris Amendment, replete with handwritten annotations. At its core, the amendment precludes, and I quote, the discarding or destruction of viable human embryos before embryo transfer. Whether or not the Harris Amendment will in effect be enacted into law remains to be seen. Regardless, though, the very notion of linking the Dickey-Wicker principle to the clinical practice of assisted reproduction represents an ominous precedent with unforeseen consequences. At the very least, active duty beneficiaries and veterans may be deprived of some, if not all, of the benefits of cryopreservation, which has been and remains the standard of practice in contemporary assisted reproduction. Mr. President, ours is indeed a house divided. Divided by our failure to define infertility as a disease, recalcitrant wealth inequalities, uneven underwriting policies, evolving socio-cultural norms, and, as you have seen, raging moral debates. However, ours is not a house beyond mending. Surprising progress and developments transpire all the time. Pentagon to offer plan to store eggs and sperm to retain young troops. Apple and Facebook offer to freeze eggs for female employees, only to be joined by Citibank and by JP Morgan Chase. Indeed, as per Mercer, the egg freezing benefit appears to be modestly catching on, at least as assessed in 2015. None of this should be taken for granted. What then should be our action plan? First, we must redouble our efforts to build a consensus around the definition of infertility as a disease, if at all possible, with the seal of approval of the Department of Health and Human Services. A win here will go a long way. Second, we must continue to advocate for infertility underwriting by employer-sponsored plans, not simply because it is the right thing to do, but because it is the smart thing to do, in that it attracts and retains valuable employees, promotes a family-friendly brand, reduces healthcare costs through plural birth reduction, tracks at less than $4 per member per month, and constitutes less than 1.5% of health benefits costs. Third, we must update our aging infertility state mandates in a manner which is commensurate with contemporary legal and ethical standards. Fourth, we must continue to press Congress to fund IVF for all in TRICARE, to fund IVF for all in the federal employee health benefit plans, to repeal the VA infertility ban. 25 years is a long time, and it's enough. Block the Harris Amendment, and while you're at it, amend the IRS code to provide tax credit for the costs of infertility treatment. Last but not least, explore and develop and continue to do so. Look for low-cost IVF options. This issue will, of course, receive significant attention at the NICHD ASRM workshop, which is slated to take place at the tail end of this very meeting. My friends, if we do this and much more, a House united is not beyond our reach. Thank you very much.